Bismillah ar-Rahman ar-Rahim. This is Dr. Ashraf Al Tayar, consultant and head of ICU in Security Force Hospital in Dammam. I'm very happy to be with you in this course for COVID-19 patients, and hopefully this will be very beneficial for all of us working in ICUs and taking care of hemodynamically unstable patients, which I'm going to present to you how can we manage a COVID-19 patient unstable hemodynamically. Thank you very much for the organizing committee, Dr. Khalid Suif and his team, to invite me to be with you in this course. And thank you for the whole team in Military Hospital, King Fahd Military Medical Complex. As we know, presentation grades for patients with COVID-19 are very variable. They might present with mild issues, signs and symptoms, moderate, severe, or critical. And severe, which is present in around 13.8% of patients, characterized by the respiratory rate are more than 30 or equal. They are dyspneic with a saturation low and BF ratio usually matching with the RDS, and the chest X-ray would show bilateral infiltrates of more than 50% of the lung. Patients is going to be labeled as critical when they have respiratory failure, shock, or AKI, or a combination of multi-organ dysfunction syndrome, more than 2 organ affected, critical. So, as I mentioned, these are the common serious presentations to ICU. As you see here, the shock is presented in around 30%. Myocardial damage, which is also present in around 20 to 30%. What I want to say, as the evidence so far showing that shock or hemodynamic instability can be present in around 30% of patients. They may present with hemodynamic instability at the time of presentation or during their course in ICU. First of all, how can we recognize shock in general? Either COVID or non-COVID, they are the same. Patients will be defined as in shock when they have evidence of tissue hypoperfusion, as evidence is showing very commonly in the literature. And everybody working in hemodynamics, the consensus or the agreement is shock should be defined by tissue hypoperfusion, when the tissue receives inadequate oxygen or they don't properly utilize the oxygen, and then because of the issues on delivery, issues on consumption, or both of them, patients then they go from the aerobic metabolism. The cells will have no oxygen, so the cells will go to anaerobic metabolism, and this will result in development of hyperlactatemia as a big mark for shock. To diagnose shock clinically, you need to have evidence that the tissues are hypoperfused. The common organs to be affected and manifested are in this sequence. Maybe the commonly you see is decreased urine output, increased capillary refill time more than 3 seconds. The capillary refill time is more than 3 seconds is a sign of hypoperfusion. Disturbed level of consciousness, and the whole cerebral function may be involved. Confusion, disturbed consciousness, coma, and many other cerebral issues that can be due to cerebral hypoperfusion. Acrocyanosis and motor dyskinesia. But this has to be in mind that shock does not require to have hypotension. Hypotension doesn't equal shock. Regardless of the blood pressure, if you have signs and symptoms of tissue hypoperfusion and patients are normotensive, they are shocked. If they are hypertensive with signs of tissue hypoperfusion, they are shocked. And a great example of this is the section of the aorta. Patient will present with shock while they are hypertensive. There are patients whom they are normotensive, but they have signs of decreased tissue perfusion, and this is what some people will call it cryptic shock, and this is well known. So blood pressure, literal definition of blood pressure is not a requirement for a definition of shock, but you have to have clinical evidence of tissue hyperfusion and micro laboratory or biochemical markers of tissue hyperperfusion. The great example of this biochemical markers are the lactate. When the lactate increases more than 2, and as more it goes above 2, indicates tissue hyperperfusion. Lactate level of 4 and above is highly linked with mortality. Central venous oxygen saturation is a good marker of tissue hyperperfusion. And the difference between carbon dioxide in the venous system and arterial system, if it's more than 5 to 10 millimeter of mercury, usually there is 3 to 5 difference between vein BCO2 and arterial BCO2. If this difference is greater than this indicates tissue hyperperfusion. Delta bicarb, of course, or bicarb deficit or acid-base deficit, is a marker of tissue hyperperfusion. And again, this is results from when the consumption, when the delivery is not enough to meet the requirement of the tissues, and the extraction ratio extend beyond the limit of the high limit that the body can do, or to reach the critical extraction ratio, then the imbalance between what delivered of oxygen and what needed by the tissue is going to result in tissue hyperperfusion or anaerobic metabolism. How you predict that your patient is having a shock clinically, or do you need something more than being dependent on assumption by measuring certain clinical examination sign and symptoms? Most of the literature shows that people who go with clinical sign and symptom to predict the cardiac index, which is the core of any hemodynamic, versus those who go with an objective parameter to measure the cardiac index. So going with subjective clinical or objective that use, for example, a thoracic echo, transesophageal echo, or invasive hemodynamic or semi-invasive hemodynamic monitoring to predict or to measure the cardiac output. Studies in the literature show that when you go with clinical signs and symptoms, this might not be enough to predict the low cardiac output or hemodynamically unstable patients. Clearly, that all signs that we rely on are not that specific and sensitive to predict the hemodynamic instability. But the most sensitive ones to maybe rely on if you don't have other alternative parameters in COVID or non-COVID patients, that the systolic blood pressure, if it's less than 90 millimeter of mercury with altered mental status and capillary fill more than 4.5, presence of mottling and EF, are good signs to predict that the cardiac output is low and lower than 2.5, which is the critical cardiac index. Signs which are not good found to be the mean arterial blood pressure, urine output, or central venous pressure. You cannot rely on this to predict if I have or don't have a normal or abnormal cardiac index. So the positive predictive value and negative predictive value of clinical sign and symptoms are not that great. While if you use transthoracic echo or transesophageal echo or other invasive or semi-invasive hemodynamic monitoring, it's found to be much better to predict the hemodynamic instability. That's why you see in the literature a lot of recommendations from different bodies, from different societies, recommending that hemodynamically unstable patients should receive critical care echocardiography at least for the initial hemodynamic evaluation, and this should be considered in subsequent evaluation, monitoring, and following up the management of unstable patients in ICU. Recommendations from all over the world is saying that every ICU should have some physicians trained in critical care echo, basic and advanced. And also recommendations are saying that every ICU should have its own transesophageal echo. Why is that? Because the echo in general, transthoracic or transesophageal, is found to be very, very useful in evaluating any unstable patients. And this should not be limited to hemodynamic instability alone, but also to respiratory instability or general instability. Because you would be surprised when you have somebody whom you don't suspect that they have abnormal echo, and they have a lot of abnormalities that might explain and change the management plan. There are some methods about the critical care echo. One of these methods that has to be changed, that the echo which we are doing in ICU has to be comprehensive, full examination. No, it shouldn't be like this. We can have our own intensive care focused, goal-directed echo exams, not like the cardiologist. No, we don't go with comprehensive. This is not the time. The frontline intensivist has to be ready with a focused, goal-directed echo exams. One of the methods also that everyone nowadays is recommending against is the critical care echo is less reliable than other hemodynamic monitoring tools. This is totally wrong. Critical care echocardiography is equal, if not superior, to other hemodynamic monitoring. Whatever protocol you go with, you have to answer certain questions with critical care echocardiography. What's in hemodynamically unstable patients, especially in our COVID-19 patients. What is the volume status? How is the LV and RV function? Are there any signs of obstruction or obstructive type of shock, like tamponade, pneumothorax, or pulmonary embolism? And last but not least is the lung wet or dry. In general, in hemodynamically unstable COVID patients, type of shock might be septic, distributive with the cytokine storm. And here you're going to see very high cardiac output, very low systemic vascular resistance, and this is due to a surge of mediators, interleukins, tumor necrosis factors, and many other things that causes severe peripheral vasodilation and vasoplegia. And the treatment of a choice here would be very straightforward, that you have to control this cytokine storm by using anti-inflammatory, role for steroid, and the vasopressors are highly indicated here. The first line of choice that we have to go with is norepinephrine. And the shock might be due to hypovolemic shock. This type of patients, they have nausea, vomiting, diarrhea, and anorexia. And that's why they present at the beginning and maybe subsequently in their course with hypovolemia, low cardiac output, high SVRI. While they also might have cardiogenic shock. And this is very, very surprising, as I'm going to mention to you later on, that cardiogenic shock should not be missed in the differential diagnosis. You have to put in mind that those who are being septic or might appear septic, they might be also cardiogenic. Or to start with, they are cardiogenic, not septic, with low cardiac output, very high SVRI. And the danger of here is if you just ignore presence of cardiogenic shock in whom they are being septic, and you use vasopressors instead of inotropic, you're going to worsen the cardiac function, and this will be associated with worsening in outcome. The most common reason for the cardiogenic shock in COVID-19 is myocarditis, septic cardiomyopathy, arrhythmias. And again, what they need is inotropes, dobutamine, levosimendan, amrinone, milrinone, whatever the inotropic drug that you might use. Combined type of shock is also found to be common. Combined means might be septic plus cardiogenic shock, and here you might combine use norepinephrine and dobutamine. So we should not forget also in hemodynamically unstable patients, the common three scenarios might be after the storm of cytokine release is myocarditis, hypovolemia, but also the RV dysfunction due to hypoxia, acidosis, PEEP, and high driving pressure. In shock management in general, you go with one of three letters. Either you go with VIP, V volume, I inotropic, support, and P pressures. So you have to ask the first question, should I give IV fluid or not for this shock or hypotensive or hemodynamically unstable patient? There are two subsequent questions, which is hypovolemia signs. Are there any hypovolemia signs? But I should not forget that the lung is affected directly and indirectly by any volume replacement. So you have to know if your patient's lung is wet or dry. This is very signs of hypovolemia. When you examine the IVC, you can get the answer immediately by eyeballing. You assess using your eye. If you see, as you see here in the bottom left, the IVC is very small and collapsing. This is very straightforward, indicated for IV fluid. And in the middle, as you see, if you see the IVC is dilated, not collapsing with inhalation or exhalation, if the patient is mechanically ventilated, then this is congested IVC and should not tolerate and cannot tolerate more fluid. On the other hand, the IVC might be indeterminate, and if here you're going to see that the size is not that big, but there is no collapsibility, too much collapsibility. And here there are other signs of that they can encourage you to give IV fluid. If you see the ventricles are collapsing, as you see here on the right side, on the left side here on the top, the left ventricle and right ventricles are collapsing and kissing, the walls are kissing. This indicates that the volume here is very depleted and ventricles are empty. If you see the papillary muscles, as you see here in the top right, that the papillary muscle in short axis view is approximating each other or kissing each other, indicates that the volume of the LV is very small. Patient can receive IV fluid. As I mentioned, you should not forget that the lung has to be dry before you decide to give IV. Again, this is dry lung, this is wet lung here on the right side. There you see pleura and vertical lines attached to the pleura, plenty number of vertical lines, we call them B lines, and this indicates a wet interstitium, indicates that the interstitium is containing fluid or extravascular lung water is high here, and giving more fluid is going to make this lung more wet, and this was found by many evidence that deleterious the increases. To give IV fluid for anybody who is appearing by echo to be full or volume hypervolemic. A big and very evident sign of volume hypervolemia is RV dilation and flattening of the interventricular septum, the septum pushed with every systole toward the LV instead of going to the RV, indicates that the RV is under pressure, and you should not give IV fluid to any patient whose RV is dilated and under either volume or pressure overload. This is very, very important. That should not give functioned patients. On the other hand, you might consider to remove fluid from those type of patients who are bearing wet lung, dilated RV with signs of overload on the right ventricle. You have to attempt to remove fluid from these patients, because if you remove the fluid, you allow the right ventricle to work under no tension, or in another word, you are unloading the RV. Important. So to sum up, the fluid in COVID or non-COVID septic patients, you have to have evidence of hypovolemia, kissing left ventricle, small RV, small collapsing IVC, give bolus IV fluid and look at the cardiac output. If the cardiac output increases, well and good. If it doesn't increase, you have to consider other way of management. If your patient is controlled in ARDS, controlled mechanical ventilation, they are in sinus rhythm, and you can put them on at least 8 ml tidal volume, no spontaneous breathing at all. You might go with other signs and symptoms of volume responsiveness, like stroke volume variation, VTI variation, pulse pressure variation, systolic blood pressure variation, IVC distensibility, superior vena cava distensibility or variability index, and then you decide to give more IV fluid or not. If your patient are spontaneously breathing or they are arrhythmic, not on controlled mechanical ventilation, have high intra-abdominal pressure, then you have to have if patients are on this way, then you can go with passive leg raising in the expiratory hold for 15 seconds, and you see if there is increase in cardiac output. You can give, they are fluid responsive, you can give bolus of IV fluid. Otherwise, you don't give IV fluid for those who are not responding to IV fluid. Responder to IV fluid means that their cardiac output increases by more than 15%. Stroke volume or VTI increases by around 12%. If the cardiac output doesn't increase, you have to be sure that there is no tamponade, pulmonary embolism, heart failure, or valve issues. False negative. Again, the hemodynamic instability might be due to a direct viral effect on the heart, what we call the myocarditis. In any septic shock patients, you have to expect the left ventricle to be, and right ventricle of course, to be contracting very aggressively or hyperdynamic, as you see here in the bottom. If you see that left ventricle and right ventricle are contracting normally in septic patients, this is abnormal for them. And if the contractility appears to be diminished, there is no doubt that you have what we call it myocarditis, or what we call it septic cardiomyopathy. Myocarditis, as I mentioned in the beginning of this presentation, is known to be not uncommon. It's found in around 20 to 30% of patients with COVID-19. They might present with myocarditis, which affects both left ventricle and right ventricle. If this is the case, the management is totally different. How you suspect myocardial involvement in COVID-19? It's common, 30%. You might use the TROB-I, it will be positive, ProBNP will be high, and the echo rule, the echo examination is mandatory to diagnose cardiac involvement in COVID-19 patients. The second question that you have to answer, and in continuity with the previous point which I mentioned about the myocarditis, is how you assess the contractility and how you can decide about using or not using inotropics instead of using vasopressors. When you see the left ventricle not contracting well, and there are 3 signs of bad contractility of the left ventricle. Number 1, that you don't see thickness change of more than 30% of the endocardium all over the different walls of the left ventricle, lateral wall, septum, apex. And normally with the systole, the endocardium increases by around 30%. And the left ventricle size will reduce with each systole by around 30%. And there will be wide opening of the mitral valve leaflets with every diastole. And sometimes we call it MAPC. We see the annulus of the mitral valve, how far it goes vertically from the baseline. This indicates systolic function. The best of views to comment on the left ventricle contractility is the apical 4 and 5, apical 2, apical 3, but also the short axis parasternal view. Eyeballing is found to be not inferior to the quantitative complicated measurements. There is no need to measure the cardiac output, there is no need to measure the ejection fraction, but just eyeballing, you assess using your eye, trained eye, to see what's the normal, what's the hyperdynamic, what's the hypodynamic, and the degrees of hypodynamic, mild, moderate, or severe dysfunction of the left ventricle. Once you see the signs of dysfunction left ventricle or hypocontractility of left ventricle, you have myocarditis or you have carditis, and the solution here has to be inotropics. Why? Because use of levophed or norepinephrine or epinephrine or vasopressin or telepressin or whatever pressin you're going to use, you increase the afterload for failing LV, and this will compromise the left. You increase the cardiac output, you have to take care of these four parameters involved in the cardiac output: afterload reduction, preload optimization, increasing the inotropicity by using inotropic drugs, and sometimes if the bradycardia, you have to increase the heart rate. Hemodynamic instability in any ERDS patients, especially if they are COVID patients. There is a well-known reason for ERDS patient to be unstable hemodynamically, which is the RV dysfunction. In ERDS patients is found to be common actually. More than 60% of ERDS patients, they develop hemodynamic instability. And more than 65% of patients, ERDS patients, they require catecholamine support. And the literature, a lot of evidence showing that the circulatory failure in ERDS is independent risk factor for mortality. So it's a common problem to have ERDS, and because of ERDS, the impact on the RV makes hemodynamic instability. There are two subsets of pulmonary circulation dysfunction here. First, if you have systolic pulmonary artery pressure increases more than 40 with RV dilation alone, we call this pulmonary circulation dysfunction. If there is RV intraventricular septum dyskinesia or flattening of the septum between RV and LV, which moves paradoxically toward the LV, we call this acute cor pulmonale. So the difference between pulmonary circulation dysfunction and acute cor pulmonale is presence of dyskinesia of interventricular septum, i.e. presence of a very significantly afterload problem for the RV to make the septum moves paradoxically, or what we call it reversible and high. This problem was found to be very common. This one of the literature which showed in a prospective study 226 patients with severe ARDS, their plateau pressure was less than 30. The ACB, although the plateau pressure was in the target area, which is less than 30 centimeter of water, but they found that acute cor pulmonale was in around 22% of patients. Very, very common. And the mortality was 60% versus 36% if there is acute cor pulmonale, i.e. acute cor pulmonale was found to be a very high risk factor for mortality. Pulmonary hypertension or RVD, right ventricular dysfunction without ACB, what we call it pulmonary circulation dysfunction, was found in a higher percentage of patients, around 50 or 48%. Half of the patients, they develop abnormality of the pulmonary circulation, and the RV will be dysfunctioned. And those type of patients, if they are left without intervention to reduce the burden on the RV, they develop acute cor pulmonale significantly. What are the causes of RV dysfunction in ERDS actually? Well, what's common, especially in COVID-19 patients, that microthrombi in situ of the pulmonary circulation, development of in situ thrombosis. A lot of research and talk nowadays about this issue. pulmonary embolism inside the lung because of the ERDS itself, because of the inflammation. But hypoxia, hypercapnia, increased driving pressure, and utilizing high PEEP are all for the RV to suffer. Mechanical ventilation setting can causes a lot of suffer to the RV, and hemodynamic, I mean the heart-lung interaction, is totally affected by transpulmonary pressure and pulmonary and pleural pressures to impact on the RV inflow and LV outflow, and both affect very aggressively the RV changes very significantly. So how can we assess the RV and we diagnose RV dysfunction in ERDS patients? Normally, the right ventricle is smaller than 0.5 to 0.6 of the LV, and it's triangular in shape and never share in the apex of the heart. Loses the shape of triangular, become dilated, and share in the apex, it's dilated RV. Normally it's less than 0.6, as I mentioned. When it's more than 0.6 to less than 1, we call it this moderate dilation. If the RV is equal or more than the size of the LV, this is severe dilation. Can be diagnosed very easily from the apical 4 chambers and from the parasternal short axis, and again you're going to see the septum is shifted or flattened and shifted to. Again, this is very important to see if there are signs of RV dysfunction to benefit of two observations. Number one, you should not attempt to give more fluid to RV like this. Number two, you should not take the prediction of fluid responsiveness signs like pulse pressure variation or systolic pressure variation or stroke volume variation or VTI variation. These variations are not going to be sensitive or specific. They can give false negative results. If you have RV dysfunction, there is a very, very good review in the literature, expert opinion on how to manage hemodynamic instability patients in ERDS. But here, again, if you have dilated RV, overloaded RV, you should not give IV fluid, and you should go with norepinephrine and dobutamine to support the hemodynamics. As I mentioned, pulmonary embolism like presentation, and this is found to be common in COVID-19 patients. They develop in situ pulmonary embolism. They have hypercoagulable states. They might develop DVT. They might develop pulmonary embolism without DVT. And how can you predict pulmonary embolism in hemodynamically unstable patients? You see acute RV dilation with a pressure across the tricuspid valve. Pulmonary artery systolic pressure is less than 60 millimeter of mercury. Dilated non-collapsing IVC, and the thickness of the free wall of the RV in the subcostal view is less than 0.5 centimeter. This are the signs of pulmonary embolism patients. And you can see a thrombus in the common femoral vein or the peripheral, the central veins, interjugular, subclavian, common femoral, or gluteal vein. Lung examination in a hemodynamically unstable patient is very important. You have to answer if the lung is wet or dry, but also you have to see if there is pneumothorax or not, because this is common in any ARDS patient and was found also to be a problem with high sitting on mechanical ventilator ERDS patients due to COVID. So if you have A profile, lung point, M mode matching with pneumothorax, this is pneumothorax. If you see B profile with signs of consolidation, this is matching with COVID pneumonia, and you have to treat that. If the lung are sliding and then you see A profile, the lung is dry, you can give IV fluid without fear that you make wet lung. If there is a sliding and B profile, pulmonary edema. You treat this pulmonary edema with PEEP. You might consider to give a diuresis. You might consider to go with CRRT and removing extra fluid if the patient develop acute kidney injury. And you should not attempt to give more fluid, especially colloid type of crystalloid type of fluid. If you see A and B and C, means you have A lines in some areas and B lines in some areas, and consolidation, this is pneumonia. To hemodynamic unstable patients, how you manage those type of patients. Hopefully it was beneficial to all of us, and thank you very much again.